All right. I noted in the book that the ancients believed that philosophy is best done amongst friends, preferably over something fermented and distilled, or distilled. My critique, which Farr has pointed out is scathing and deep, should be understood as a friendly critique. I point this out in the book. It's meant to be friendly to medicine. It is in friendship with medicine, I would argue. In fact, I wish the wine was being passed up and down the aisles right now. You probably do as well, after hearing all this rarefied language of philosophy and formal and final causation. But diagnosis sometimes requires that we abstract from the superficial elements facing medicine and to dig a little bit deeper. And that's essentially what I did in the book. First of all, I sort of start from the assumption that the kind of thing we think we're dealing with when we're dealing with the body shapes the kinds of things we think we ought to be able to do or should do when we're dealing with that body, which means that there are metaphysical assumptions in all of medicine. But before I continue with the philosophically rarefied language, I would like to thank Lydia Dugdale for putting this panel together and for herding us, which is a real task. And I was probably the worst at responding to anything, so I apologize for that. I would also like to thank Farr for taking the painstaking time to carefully to read the book, for articulating the main thesis of the book so clearly. In addition, I want to thank Frank Miller. Frank and I came to know each other over a case, which I hesitate to call a case at all, for it minimizes the significance of the person whose case Debbie represents. So, though I never shared any of the text from my book with Frank, Frank and I had several opportunities to discuss the ideas of the book, once over dinner honoring Debbie, and once here at an ASBH meeting. In addition, Frank, along with others like Bob Troop, have been my dialogue partners through their publications. In part, it was part of the clarity of Frank's papers that allowed me to see so clearly the kind of metaphysical assumptions that animates the work of modern medical practice as well as modern medical science. My book came out a few months before Frank's and Bob Troop's book, Death, Dying, and Organ Transplantation, the book that Frank just put up. So I did not have the chance to cite this work in my book, but their book seems to confirm my critique that contemporary medical science shifted the meaning of formal and final causation, elevating efficient and material causation. And as Frank just said, that's really all there is efficient causation. As Farr pointed out, the main thesis of the Anticipatory Corpse is that the dead body is epistemologically normative for the work of medicine. This thesis is not just in the sense that our first patients tend to be dead, though that is certainly true. It is also true historically, in that modern medicine seemed to take off around the time that gross anatomy became commonplace at the end of the 18th and the beginning of the 19th centuries. Body snatching and grave robbing were on the upswing then as well. There was a kind of fetishism towards the dead body. Typically, the reason cited for this practice of body snatching is that society, fueled by Christian churches, had prohibited dissection. What is fascinating about this story, it's a fabricated story, is that law and church teaching had for the previous 200 years allowed for dissection to happen. Instead, what fueled this frenzied activity of dissection was the place the dead body was coming to occupy, as described by Michel Foucault. The dead body had come to act as an anchor for medical knowledge, the sure ground for its material science. The dead body had become an ideal type, speaking its truth about death, life, and disease. And in the light of the dead body, the truth about life and disease would become evident. This fundamentally different way of seeing or knowing the body led to an interesting idea, namely that the difference between living and non-living matter was quantitative rather than qualitative, a continuum. In other words, there was no difference in kind to explain the difference between inorganic matter, that is to say dead matter, and organic matter, or living material. In other words, I began to see that this epistemological stance contributed to the rise of a metaphysics of efficient and material causation, with the diminution of a metaphysics of meaningful form and final causes. So taking this note from Foucault, I explored the rise of modern life sciences, namely physiology, and the idea that the body is a dead machine, dead matter in motion. And all that was left to figure out was the kinds of forces that were involved in the living body. And when those mechanical forces stop, we come to replace them with our machines to keep the mechanism going. I explore this idea through the physiological literature and into the literature of statistical medicine of the 19th and early 20th centuries, from the anatomy lab into the surgical suite, and from the physiology lab into the ICU. I trace the way that the language and values of the anatomy lab and the physiology lab move directly into the clinical arena. This movement is best seen in two ways of describing donors that would later in the organ donors that would later in the 1960s lead to the concept of brain death. So before the phrase brain death ever existed, before that phrase was ever used, the probably dead, brain dead person was referred to as a living cadaver or as a heart-lung preparation. It is clear from the term living cadaver, it just derives directly from the anatomy lab, right? The cadaver, the dead body, the non-living body, the living, non-living body, essentially, is what they were saying. So what is less clear is this phrase heart-lung preparation. In the 1940s and 1950s, and even into the 1960s, and even in my own training in the early 90s when I did physiology, we still went to the dog lab. And a heart-lung preparation was essentially referred to the way in which the dog or other animal had been prepared to run experiments on blood pressure, heart rate, and oxygenation. So in other words, we can trace the movement of this language from the anatomy lab into the surgical suite and from the physiology lab into the ICU. All right. I even show how this efficiency mechanism moves into the social apparatus of the ICU and into organ procurement and into a biopsychosocial-spiritual medicine. And this is where I was more afraid of this group than anybody else. I began to see even how it affected palliative care. Now let me drill down a bit, and specifically to shift to Frank and Bob Trug's point that they have been arguing for. Historically speaking, say prior to the rise of modern medicine, the idea that human purpose and meaning were part of the fabric of the world, that the world itself contained a kind of meaning and purpose. The material of the world had begun with the formal cause and moved to the final cause being that for the sake of which the world existed. Form, function, and purpose all went hand in hand. Call this a thick metaphysical worldview. However, in order to gain control over the mechanism of the world, the meaning of the world had to be deflated. And in our day, amongst the intelligentsia, there is no meaning or purpose to the world. Instead, the dominant Western paradigm of liberalism allows only the autonomous will and its sole as its sole metaphysical principle. It is that will that insists post hoc, that invests post hoc the material of its body with purpose and meaning. The conundrum in which we find ourselves when a person is approaching the end, the terminus of her life, is that medicine must act and does act as if the material of her body had little significance except insofar as she had granted it some meaning or purpose. That is the cold reality that we face in the ICU, or when faced with Terry Schiavo, or donation after cardiac death procedures, or the new organ procurement mantras of 8 organs every time, all directed towards efficiency and effectiveness and ruled over by this dominant metaphysics of efficient causation. And we wonder why we find medicine so cold and impersonal, and at the same time desire its efficiency and its effectiveness to keep us living, to keep us alive, or efficiently to dispense with us when we decide it's time. My book is a hard book because it does not accept the typical diagnosis or therapies offered to an ailing medicine and the medical establishment. It digs deeper. Our tendency is to not want to know about the necrotic cancer that has become super-infected at the heart of medicine. And so we deal with the superficiality of its problems as they arise. Medicine seems harsh. Let's get students to read some humanities. Let's get them to read some novels and some poetry. Medicine seems to be keeping alive people too long. Let's add patient decision choice to the mix. I'm all for that. I'm not diminishing. I'm saying it's not addressing the problem, though. It attenuates the problem, perhaps, but it doesn't address the heart of the problem. Patients find their existence intolerable in the ICU. Let's give them the chance to not only turn off machines, but to efficiently end their own lives. These are mere band-aids to what I would argue is ailing medicine at its heart. Now let me turn specifically to Frank's challenge. I want to pull up a quote from his slides, and he attempts to, as he attempts to narrate the cause of death in a person desiring the withdrawal of life-sustaining treatment. In inquiring why a person died, this is a direct quote. In inquiring why a person died, we are seeking to explain why she died at a given time. Now there's a lot there to unpack. First, notice that he used the term why, but his description is a common sense discussion of how the actions lead to death of the patient. So we are wedded to a metaphysics of efficient causation, and that, we are so wedded to a metaphysics of efficient causation that we have taken the interrogative why, which had for centuries carried not a mechanical but an existential meaning. Okay? So when a patient asks, why do I have cancer? We say, well, you smoked, and you had certain tumors of broder. You know, we start answering a why, an existential question, with how. Okay? We have so moved to this metaphysics of efficient causation. Yet, at the same time, there is a holdover of some kind of a kind of existential and therefore more meaningful and purposeful language in the why question. Its ambiguity allows us to forget that knowing the intention and motivation of an act becomes confused and confusing. I agree with Frank that you can't figure it out sometimes. This is why we forget the deeper meaning of intention and intentionality and focus only on the effect, something that we can get our hands on, something we can measure, something we can see. So why do I turn off a machine for someone who has made his or her peace and ask that the machine be turned off? Because he or she finds his or her existence on the machine intolerable. Now, if that person breathes on her own, I do not then follow through with a bolus of potassium chloride to stop the heart. Instead, I marvel that I got the diagnosis wrong. Right? We marvel at that when we get diagnosis wrong. We can't believe we get it wrong, right? I marvel that something more is going on, that something else is possible, that the person has the opportunity to maybe once again re-narrate his or her life. Of course, it is acceptable for patients who find life-sustaining treatment to refuse it. To accept this is not to will the death of the patient, nor is it to cause it in any existential sense. For if she lived a day, a week, a month, a year after its removal, I would not think that I had failed in my action. To presume otherwise, to presume that I did fail, only confirms my suspicion that medicine has deflated richer and thicker understandings of the body as irrelevant to our actions as doctors. In other words, Frank's and Bob's most recent book describes precisely the metaphysics of efficient causation that dominates the medical establishment. And it is this metaphysics that ails medicine. It is this metaphysics that results in our perception of medicine as cold and impersonal. It is this metaphysics that results in the subtle violences of coercion felt at the hands of medicine. Frank's answer and the answers given by medicine are still metaphysical positions, no better or worse than the older metaphysics that suggests the world and that our bodies have a meaning and a purpose beyond the mere mechanical functioning. And that means, I would suggest, that even in our dying, we cannot find meaning and purpose. That even in our dying, we can find meaning and purpose. Our bodies do have teli. My body has a telos, and not merely a terminus that anticipates the corpse. Thank you very much.